will be about the results of the mini-histerotomy. Nowadays, 21 centers in Brazil are using the mini-histerotomy to correct fetal spina bifida. I trained all these centers by myself, and today 12 of these centers are fully trained. They are doing it individually by themselves, and 9 centers are still in the process of training. So the objectives of this presentation is to show the overall results of fetal spina bifida repaired through mini-histerotomy in 10 of these centers. 9 of these centers I'm still present in all the surgeries. And the other 2 centers with a bigger number are one center in Rio de Janeiro, coordinated by Professor Jair Braga, and the other in Minas Gerais, coordinated by Professor Fabio Batistuta. We'll also compare our results with the MOMS trial. And the second objective is to carry out a prospective validation of previously published prediction formulas for VPS, for ventriculoperitoneal shunt, and ambulation in these patients. So the selection criteria for fetal surgery is basically the same as those in the MOMS trial, except that we allow surgeries in later gestations. We don't require genetic testing in all the cases, and not even an MRI. And the BMI limits are not a problem for us. We operate on any BMI of the maternal BMI, sorry. So as a summary of the selection of cases for this presentation, for the overall results, we will show all the cases that we have complete information from delivery until June 2026. For the validation of the prediction model for VPS, which was published by our team a couple of years ago, we'll use all cases in which the children is over 1 year old. And for the validation of the prediction model for the ambulation, we'll use cases in which the children are over 2.5 years old. And this formula was already published before too. So overall, we have done around 970 surgeries, all the 3 centers. And for the overall results, the ones that we have complete information from birth onwards, we will use 670 patients. For the validation of the formulas, for the VPS validation, we were able to gather 416 cases. And for the validation of the ambulation formula, around 200 cases. So talking about the overall results, you see here in this graph that I compare our overall results in Brazil with the MOMS trial results. And I also do a comparison among the Brazilian centers. I check to see if there is any difference among them. So regarding the selection criteria for the surgery, the gestational age of surgery, in our centers, there was just one center that the median gestational age of surgery was a little bit later, and this was mainly because of the delay in the referring process. About the perinatal outcome, our results are very similar to those of the MOMS trial. I couldn't find any difference between our centers in Brazil, but our data from Brazil differs from those of the MOMS in terms of the gestational age at birth, which was a little bit later in our centers, with lower cases delivering before 34 weeks. About maternal complications, we also notice a difference in uterine dehiscence comparing the mini-histerotomy with the classical hysterotomy for spinal bifida repair. No difference between Brazilian centers. Another aspect that we observed was that there was an inverse correlation between the gestational age at surgery and the interval from surgery to deliver. So the lower the gestational age at surgery, the bigger the interval between surgery to delivery, despite there was a positive correlation between gestational age at surgery and gestational age at birth. But we can see in both graphs that there is a group of patients that will deliver very soon after the surgery. And I was curious to check what happened here. And the only variable that actually interfered with this very early delivery after surgery was the occurrence of chorioamnionitis, which actually was not a very common event. When we go for the model validation, and so firstly the validation of the formula for ventriculoperitoneal shunting, we see on the left that in the formula generating group there was an influence of the gestational age on postnatal ventriculoperitoneal shunt, and also the size of the lateral ventricle before surgery on the chance of postnatal ventriculoperitoneal shunt. In the validation group, we also saw this, this influence of gestational age and the size of the lateral ventricle in postnatal ventriculoperitoneal shunt. And when you go for the calibration plot in the upper left graph, we see that the results are quite okay, but we underestimate a little bit the chance of ventriculoperitoneal shunt in the validation formula. But even so, we can notice in the ROC curve that we can that we have a pretty good performance of this formula, and we can establish we can calculate different chances of postnatal shunt depending on the cutoff value calculated by the formulas. When we go for the validation of the model for the prediction of ambulation, we also saw in the right graphs here that there was an influence of gestational age at surgery and the chance of ambulation with or without orthosis. And again, in the calibration plot on your upper left graph, the results are quite okay, but we overestimate the chance of ambulation applying the formula to the validation group. The ROC curve, the results were not so good, but still we can calculate for different cutoffs a detection rate for the ambulation for a certain value of false positive here. So in conclusion, we see that the overall results of spinal bifida repair through mini-histerotomy seem to be very similar to those of the MONS trial, except that we notice a higher gestational age at delivery and lower numbers of deliveries before 34 weeks. And comparing my results in the centers that I still participate in all the surgeries with other centers, it seems that the technique is quite reproducible. The results are really similar. And the second conclusion is that the prospective validation of the prediction formulas for VPS and for ambulation, they appear to reinforce the impact of the gestational age at surgery on the outcomes. Thank you very much for the attention.